of Health. I'd like to appreciate all the colleagues who have logged in from the facilities. We can see that some individuals have joined using their devices, but we also have institutions, people gathering in their institutions who have also joined as a group. So we would like to welcome Nangongwe Health Center. I can see that Kehema also has managed to join, but all the facilities from wherever you've joined in, we would like to welcome you to this today's meeting. So you are welcome, Mr. Chimuka.
Thank you.
Would you like to welcome our participants today?
Okay, good afternoon, everyone. I'm looking forward to learning from you and also for listening to us. Thank you.
Is there something you would like to add on to your presentation? Of course, I gave your name and also your position on the Ministry of Health. Is there something else maybe you would like to add on?
No, so
that
far
people can get to know you.
No, so far so good.
Okay. Okay, thank you so much. So we are going to start with our meeting. We encourage everyone to use the chat box. In case you have got any question, kindly use the chat box. Of course, we are going to have time for Q&A. And also, I think the link has been shared in the chat for registration. Kindly take time to register because it's very important. So we are going to start with our meeting. Yes, over to you, Mr. Chimuka.
Okay, so thank you very much. So our objectives, the first objective is just for us to be able to share the updates with regard to the new inclusions into the HIA2 the portables into the DHIS. The other one just to demonstrate documentation and also the use of some of the updated tools. So we have a poll. The first poll, maybe people can respond.
Okay, so we are going to move on to the polls. The first one, Chimuka, I'm going to launch the poll a bit later, but let's go through the question itself. Chimuka Sianyinda, Rural Health Center, reported the following first and contact 100. Non-HIV positive at first rank 15, already on ART at first 17. As a DHIO who received the above report from the facility, what correctly defined the situation? Question option A, the facility submitted incorrect data. B, the facility submitted the data submitted by the facility was correct. C, it is difficult to determine if the data submitted by the facility was correct or incorrect unless the document registers were reviewed. So I'm going to launch the poll now.
Yeah, you can launch it.
Okay, all right. Thank you. I'm going to launch the poll now. We are encouraging all the participants to give it a try. So once again, I'm going to go through the question as people are voting. Chimuka Sianinda Rural Health Center reported the following. First ANK contact 100, non-HIV positive at first ANK 15, already on ART at first 17. As a DHIO who received the above report from the facility, what correctly defined the situation? Is it the facility submitted incorrect data? The data submitted by the facility was correct. It is difficult to determine if data submitted by the facility was correct or incorrect unless the documents were reviewed. So thank you for all those who are voting. But our voting rate is still very low. Kindly vote, please. We stand at 30% voting rates. We expect to reach at least 60% before we stop the polls. I would like to say that we are 290 participants so far. Only 110 have voted. So we are expecting people to vote before we move on to the next poll. Unfortunately, I'm not able to see who has voted and who hasn't voted. So we really encourage people to vote. 45% so far. I think, is it that the question is difficult?
Seems confusing for them.
Yeah, okay, all right, at least we are at 50%.
Okay.
So today we are going to proceed a bit. I'm going to end the poll. We shall proceed a bit differently. The presenter wanted us to, let me share the result. Yeah, so at least you can see how people voted. Most of the people have gone for option C, and they represent 54%, and 39% have gone for option A, and 7% option B. So as I was saying today, we are going to discuss about the answers, then we shall move on. Over to you, Mr. Chimuk.
Okay, so as you can see that, is it 3% where they said, the answer as well? Yeah, so as we can see that the majority of the people, they have said what the facility reported was
C?
No, I'm saying no, B.
Yeah.
The majority have said what the minority have said what the facility reported was correct, which is answer. So now the issue was between A and C.
Yeah.
So colleagues, there are certain answers we get from the facility by just looking at the report. Others, you need to go to the facility and verify. Whilst for others, you do not. So for example, if a facility reported to say they have non-positive are 15 and already on treatment as 17, so we don't expect such a report. So the answer is A. So what the facility reported was incorrect because in short, what I'm trying to say is that there are certain data elements people report. You don't have to go to the facility to go and verify. Mm-hmm. By the virtue of looking at a report would be wrong. So the correct answer was A. What Sanyinda Chimuka facility reported, the answer was incorrect because the non-positives were less than already on treatment. So expect already on treatment, we expect the non-positive to be more or equal to those who are on treatment.
Thank you so much. I believe that this topic is relevant because we can see that the majority has gone for the wrong answer. So we shall move on to the second poll question. Okay, all right. Let me just launch the poll. Let me just launch the poll. Second poll question. So we can see that which one is correct about, which one is correct? Yeah. Just a minute. Okay, all right. Which one is correct? Mwelwa Sianyinga is an HIV-exposed child born on 10th April 2021 and is seeking HIV-related services at Ndeke Urban Center. Mwelwa was tested at birth 6 weeks and 6 months. with all three tests being negative. At 7 months, Mwelwa's mother got him a transfer to a location urban center, and the facility gave him the transfer on the same day. So these are the questions. A, his final outcome was negative. B, his final outcome was unknown. C, it was a loss to follow. And D, none of the above. Yeah, people have started voting. I was a bit worried because apparently people were still reading, going through the question. So 35%, but 14%, 15% voting rate so far. So let me read again the poll question. Mwelwa Sianyinda is an HIV exposed child born on 10th April 2021 and is seeking HIV related services at Ndeke Urban Center. Mwelwa was tested at birth, 6 weeks and 6 months, with all three tests being negative. At 7 months, Mwelwa's mother got him a transfer to location urban center, and the facility gave him the transfer on the same day. So the question we want to know. Okay. Okay. Which one is correct about the reports of Ndeke on Mwelwa Sianyanda's outcome at 24 months? His HIV outcome was negative. Yeah, so thank you for those who have already voted.
Yes, there's this part.
Okay, I'm sorry, there was a part missing. Okay, it's saying in May 2023, Ndeke Urban Center is finalizing the cohort report for the April 2021 HIV exposed cohort. Which one is correct about the report of Ndeke on Mwelwa Sianyanda's outcome at 24 months? His final outcome was negative, his final outcome was unknown. He was a loss to follow, none of the above. So let's see the voting rate. We can see that only 42% the participants have voted so far. We are 319, 20 actually, who have managed to log in. So we expect people to vote at least 50%. For those who haven't yet voted, kindly give it a try so that we can move on to the next poll question. 44% of the participants only have voted. Kindly vote, please. Kindly vote. Kindly vote. So there is a hand up. I don't know if at this point we should give the opportunity, maybe switch that on, yeah. Okay, all right, I'm going to end the poll right now. 47% only of the participants have managed to vote, so I'm going to end the poll now. Mr. Chimuka, over to you.
Okay, so with regard to the answers we have, first we expect that C is not part of the answer because we're looking at PMCT outcome. There are three possible outcomes. Either the child is infected, the child is not infected or negative, or the child is unknown. So the first one we're eliminating is C. So issues of loss to follow, defaulted deaths are not the final outcome, but they can influence the final outcome. When we talk of A and B, they are not the correct answer is because if you're dealing with a cohort and a child, if the status was negative and the child is transferred out, that child is no longer at 24 months, for that facility in Ndeke, they transferred the services of tracking this child. So that child is no longer in their hands. So the correct answer is none of the above, because in Ndeke, when they'll be doing the final analysis at 24 months, this child went to them to report that I'm no longer, I need to be transferred out. So the correct answer is D, none of the above.
Okay, all right. So I think we need to move on to the next question 4. We are sorry because we are using a new machine and we are facing a few technical issues. Just give us, I think, 2 week time or we shall get back. So. Okay, so I think we are using a different machine. I hope you are able to hear us. Just type something in the chat if you are able to hear us so that we can proceed. Thank you so much for that feedback. Before maybe we proceed, there was a hand up in the chat box. So I will give the opportunity to the one who has a hand up to make his contribution. Go ahead.
Hello, Chair. I wanted to remind you that the slides were not moving, couldn't get the whole scenarios for the question that you are leading from.
Yes, Paul. Sims.
Yes.
Your hand was up.
Yeah, I wanted to comment that the slides were not moving, couldn't see the scenarios that you are leading through.
Recording in progress.
Okay. Thank you so much. So I think I did mention that we are facing a few challenges with a few technical issues here. We are trying our best to proceed with the meeting. Points taken. So we need to move on to the next poll question. Are we going to Mr. Chatonda? Can I share the poll questions from here?
Yes, please. Let me make you co-host. Okay, you can go ahead.
Okay, all right. I'm going to share the third poll question to launch it. Are you able to see the poll question number 3? Just, I'm going to go through, to take you through what statement is correct about HTS numbers reported on HIA2 reports on age and sex. Those numbers represent the HIV test from VCT only. Those numbers represent all the HIV tests done at our facility. at facility in a particular month, excluding VMMC and the PMTCT numbers. They have their own section on HIA2 form. And the third option is that those numbers represent all the HIV tests done at facility in a particular month. So I will go through again. What statement is correct about the HTS numbers reported on HIA2 reports on age and sex? The numbers represent the HIV test from VCT only at a facility in a particular month. Option B, those numbers represent all the HIV tests done at a facility in a particular month, excluding VMMC and PMTCT numbers. They have their own section on HIA2 form. And the last option, C, those numbers represent all HIV tests done at a facility in a particular month. So far, 30% of the participants have voted. So we still have a lot of people who are still doubting. I know that most of the participants are clinicians. Maybe they are not familiar with
but the ones who do the reports.
Yeah, they are the ones who do the report.
Yes.
Okay, all right. So they have started voting.
Yes.
Okay, all right.
Especially on this one, it's encouraging.
Yeah, it's encouraging.
Mm-hmm.
So let's not leave this question to the M&E team only. We encourage the clinicians to participate. Our voting rates stand at 42% so far. Let's reach at least 50% before we hand over to Mr. Chimuka for the feedback. 40%, we are stuck at 40%. Kindly vote. Okay, all right, let's vote. I don't know if I should go through the question again, but I'm sure you are able to see the question on the screen. So for the sake of time, I think we are going to end the poll here. Our voting rate stands at 48%. I think it was wrong maybe to share the. Okay, I'm going to end the poll now and share the results. So we can see that the majority of people, 68%, yeah, they have gone. Yeah, they have gone for option C.
Yes.
And B has recorded 30% and 2% for A. So over to you.
Okay, so I think in this regard, for question number 3, we seem to have obtained 50 plus 1. So no need of variance. So the correct answer is C, like what the majority responded. So regardless of other HIV testing points, because if you check in antenatal labor and delivery, we just capture the number of people tested. So the HTS part, what we want to profile is a demographic in terms of the demographic profile of the HIV program in terms of the age and the sex. So regardless of where this testing will be done, on the part of the HTS, it's for all HIV tests done at a particular facility, which has to be added in terms of age and sex.
Okay, thank you so much. I'm going to launch, we have got 6 poll questions. After this, we are going to have the didactic presentation. So I'm going to launch the 4th question. Yeah, so the question says, let's move on to the 4th one. The question says, what statement is correct about the HTS numbers reported on HIA2 reports on age and sex? Those numbers represent the HIV test from VCT only at a facility in a particular month. True or false? What statement is correct about the HTS numbers reported on HIA2 reports on age and sex? Those numbers represent the HIV test from VCT only at a facility in a particular month. So we only have two options. Is it true or false? So it's good to see that, yeah, people.
This one. It's on the time.
Okay. So the question is, state whether it's true or false for the following statement.
It's HB ones. Maybe they can
They could have been switched. That's the question. This is the old one. It should be like, oh.
You can change it.
Let's see.
Okay, I'm going to end the poll here, then give time to Mr. Chimuka maybe to make some comments.
True. Okay, so maybe it's these are the questions now.
So I've ended the poll
Changed.
and share the results.
Okay, we can just discuss them.
Yeah.
Yeah, Mr. Chimuka, you
Okay.
can.
So here, what we are just trying to bring out are the issues of there's the biggest one. Biggest one. So maybe in the name of time, we can discuss the three of them. So what we are just trying to bring out here, there are certain data elements which speak to each other.
Yeah.
They should be equal. So for example, when it comes to which one are you able to see? Okay, let's go to 6. So for example, there is a data element which talks about exposure status as penta 1, and also those children get DPT at 6 at penta 1. So the two are equal. So we don't so if a facility reports that 20 children received DPT 1, we expect on the HIV part for a facility to report what is the exposure status for that child who got DPT 1. Is that child exposed? Is that child exposure known? Or that child is not exposed? The other element also is to do with, let's go to 3. In the name of time, it's freezing. So the other aspect we wanted to discuss also is the issue of the ART timing. So the ART timing on the HIA2 should be equal to those started on treatment. Or what you're just trying to say is that if facility A reports that 20 people started on treatment, it's for those 20 people want to ascertain from the time they tested positive, how long did it take for them to start on treatment? So the two should also be equal. The other aspect we wanted to just discuss is that started on treatment should be, is a subset of current on treatment. So don't expect a facility where you have got more people starting on treatment than current on treatment, or where you forget to add the current on treatment, the newly started to the current on treatment.
Okay, thank you so much. So I'm going to request Mr. Chatonda to share again the link, registration link in the chat box. People are claiming it. Yeah, so bear with us. We are trying our best. We are facing a few technical issues here, and time has really gone. So for the sake of time, I'm going to request Mr. Chimuka, who is the strategic information officer at Lake House, to proceed with the clinic, the didactic presentation. Okay. I think we shall come back to the two questions later.
Thank you.
Yeah.
So thank you very much, Doc. So go straight into some of the new inclusions. So because we don't have enough time, so other areas which are not that critical, I'll be a bit fast and then spend more time on certain data elements which require a lot of discussion. So, and for those who have been long in the system, you recall that previously we used to also report on the test happening in family planning and also the unmet needs. So what we have just reintroduced are the data elements we used to have previously, where they'll be able to screen the mothers who need to be tested, who qualify to be tested, and then we'll also be able to capture of those how many were tested. I should make mention that for these two data elements, ideally they're supposed to be one is supposed to be the subset of the other. But taking into account that we live in a normal environment, I can be screened to have unmet needs for HIV testing, and I may decide to test a week later, which may be in another month. So we may expect that sometimes it will be expected to have more tested than the unmet need, because people may not test there and then. So it's possible that others would have been screened that they need the services, but they may test in another month. But we should ensure at least those who have unmet needs. If you're testing, we test them there and then. Then we can move on to the other. So we seem to have a challenge with.
Okay.
Okay. So this other aspect, or what we're just trying to also bring out, is the issue of seeing whether our policy on exclusive breastfeeding for 6 months is working. So this data element should be filled in for children that have clocked 6 months, and we want to just ascertain for that child, for those children who have clocked six months in a particular month, how many were exclusive breastfed, how many were on exclusive formula, and how many on other food. So we just want to ascertain and see how are we performing with regard to the issue of infant feeding. Okay. The other aspect I'm moving to is antenatal. As you may be aware that as a country we are now moving towards the triple elimination of HIV, hepatitis B, and syphilis. And we do have 3 ingredients we track in terms of antenatal services itself, the coverage of antenatal. The other aspect is what's the coverage of testing for either of the 3 we are interested in. And the third one, which is also very critical, is the issue of, for those who have been reactive to any of the 3 you're interested in, have then been put on treatment. So you will learn that previously, again, we didn't have we had the treated of syphilis, but I think the previous division was omitted, so we have just reintroduced it. And I'm just trying to emphasize its importance that as we do as we assess ourselves towards the path to elimination of any of the 3 diseases we are tracking, treatment is very important. So we are putting an aspect of treatment. So I've brought in the issue of treatment. So in this case, the new thing I've brought in is for those who are the reactive test for syphilis, how many were are treated. The other aspect you have brought in, okay. So the other aspect you have brought in on the HIV testing, as you may all know that HIV self-test is also one of our game changer when especially for those people unable to come to our facilities, especially the males and other hard to reach population. So here, colleagues, it's not the actual test we are tracking, but what we just want is for a facility to report the number of HIV self-test kits which somebody received or the issue. So here it's just like the way we do with the condoms, where we track the number of condoms distributed.
So may I request those who are not allowed to speak to mute their mic, please? Kindly mute your mic. Mr. Godwin Cantolomba. Your mic. Okay.
Okay. Yeah. So I was just trying to emphasize that the self-test we're talking about is the kits which could have been distributed, and not when somebody actually has tested and they've gone to a facility to confirm. Here we just want to track the distribution into our community with regard to the HIV test. The next part we are moving to is with also still under HIV testing. We just want to itemize some of the changes we have brought in. If you remember very well, previously what we used to have was HTS fixed, community, and also we used to have HTS community. As you may be aware that all the HIV testing happening in a facility, they are all fall under the HIV testing. as in HTS. But here what we're just trying to establish are the entry points, from which point does somebody test from. So the first part we have introduced is the visit. Remember, visit this is when it's me who wants to test. And the only reason I've gone to the facility is because I want to test. So I can test either in the community or at facility. But anyone else can still test either in the community or in the facility. But what would have made them test is because they could have gone to seek one service, and the HIV testing is embedded in that service. So what we have just edited is on the HTS. Then I should also make mention that don't be surprised, we can also be able to test people in the HIV care and treatment, especially that PrEP and PEP are mostly embedded in the HIV care and treatment services. So you may have somebody who wants to access PrEP, as we all know that our guidelines require that I'm tested. Equally, one may be in a discordant couple, they may escort their partner, and they may be able to test. So what it implies that it's also okay for a facility to place the HIV testing register in the ART room, just in case there are people who may need a service to test. So nothing much has changed with the other one, because just responding to what I've already explained. So here we're just trying to look at the positivity from those entry points. So it's similar to what we already discussed. Okay, so the next one is on the PMTCT part with regard to the testing. So what we have amended, again, for those who have been long in the system, you remember that we used to track at what point did I test? Did I test for the first time? Did I have my initial HIV test the first time I went for ANC? Or I tested for the first time during my subsequent test? So in this regard, what we have now done is that previously what we used to have, the immediate past documents or two, what we had was just an initial HIV test. So this one, we were tracking the first test a woman could have had, regardless of the timing of the first ANC. But in this point, we also want to, we have separated the two. This will also resonate very well with the elimination path, where we want to be measuring how many people are testing. So Doc, you agree with me that previously, it was very difficult for me, for example, or for anyone at the facility, when you look at the first ANC numbers you had and how many tested. It's the same issue I was discussing, where I can go to a facility today, they don't have testing kits, I don't test. So when you compare antenatal and the first test, sometimes you'd find the tests were more than the first ANC, because somebody could have been testing for the first time on the subsequent. But with a new revision now, we're able to separate. So in this case, I can still be able to get the first ANC and check how many tested in the first ANC, and also be able to get the KPs. And when I add the two, I expect the ANC, the first, I can see what's happened to this facility, but previously it was very difficult. The other aspect you have also brought in is the issue of the test done during the breastfeeding period. Studies have also equally shown that a number of the children actually who are being infected are those whose mothers should convert during breastfeeding. Because when it comes to testing, we're doing very fine as a country. We're almost above 90% when it comes to testing. So meaning those mothers who are positive, we are putting them on treatment, and the prevention is working very well. But the problem comes in when it comes to subsequent testing of these mothers. So we have brought in the retest during the breastfeeding period, where we expect the mother to be tested. Also, the other aspect Doc wanted to bring attention to our colleagues is that, as you may be aware, that when it comes to the testing eligibility for a woman who is during labor and delivery, and also during PNC, it's 6 weeks. But when you look at our numbers, you find, off my mind, if I'm not mistaken, we only had about 500,000 women who tested, both from the retest during antenatal, initial ANC, during ANC, and also during labor and delivery, and also PNC. So I'm just trying to say, colleagues, that when you look at the indicator number HIA2, 040, that's the retest for ANC, labor and delivery, and PNC, is that because when a woman who is in labor and also a woman who is doing labor and delivery, their last HIV test, it's only valid for 6 weeks. So what it implies is that if a woman during labor and delivery, if the last test was beyond 6 weeks, it means you need to test that woman during labor and delivery. If when a woman came to deliver, her last test was within 6 weeks, it implies that during PNC, either 6 days or 6 weeks, we have to test. So by implication, what we're just trying to encourage our colleagues that we have been not doing well when it comes to the retest, especially in labor and delivery, because we're not we're not following the guidelines that the test is valid for 6 weeks. Then afterwards, we revert back to the 3 months. So we have been seeing a very low testing, especially the retest between especially the labor and delivery. So we expect the numbers to actually increase. The other aspect, I think there isn't much here now which we have brought. The other aspect is just the same thing I was just talking about with regard now. The only new thing which is there is just the positive. How many actually tested positive? Those breastfeeding mothers between 6 to 24 months. Again, here, the other aspect we have just brought in, the only two on PMTCT with regard to those starting treatment. So, Doc, again here, one indicator, like I mentioned, that this falls under the treatment of the triple elimination. Treatment is also very important. So, one for HIV programming, when it comes to the 3 process indicators we are tracking, when it comes to anti-coverage, we seem to be doing very fine. When it comes also to the issue of those who are eligible to test, how many are testing, we seem to be doing very fine. But when it comes to treatment, of the 3 process indicators we're tracking, treatment seems to be on the lower side. So wanted also to see where are we missing. So when it comes to those started on treatment, what we have separated are those that, because those starting treatment, there are 2 groups. There are those who test in MCH setting, which they have tested for the fact they have been classified to be HIV positive in the MCH settings, and they start treatment. We also have a group of people who are starting treatment.
Sorry for the disturbance. We're going to mute this one. Yeah.
Okay. So I was saying we also have got a group of people who are KPs who start treatment in MCH. So wanted to see where is the problem. So we have separated the 2. So wanted to know how many KPs are starting treatment in MCH and how many those who tested within MCH tested positive and they started on treatment. I should also make mention, Doc, like part of the poll we had, there are certain instances where we have already on treatment at first ANC, which is more than the KPs. So we don't expect that. So we expect already, because when people go to a facility, the first thing they're asked is, what is your HIV status? Then somebody will say, I'm non-positive, I'm already HIV positive. That's when they'll ask a subsequent question, are you on treatment, yes or no? So we don't expect those who are saying I'm on treatment to be more than those who are saying I'm already HIV positive. Then the other aspect we have just brought in also is the issue of women receiving cotrimoxazole. HIV positive women are receiving cotrimoxazole. The next one we move to, again under PMTCT, is on the issue of EID. I think here I may need to take a bit of time so that we don't confuse people. Previously, Doc, where we're coming from, what we used to capture, where we were capturing the positivity at a particular point in time. So we would capture first those who are testing for the first time, those who are having a retest in that age group, and then how many were detected to be HIV positive. Thereafterwards, we would go and look at the cohort. But because of other changes, so the changes have brought in that this part here, what we are tracking are the samples let me just say what we are tracking is an indirect method of estimating the children who are exposed. So when we come into a contact with a child and we're able to draw blood samples, and those blood samples for this child, that's what we document. Because previously, what we used to document was a facility to draw blood, send the DBS sample to the lab. When the lab have done the test, when they bring a valid result, that's what they used to report here. But here, what you're interested in now, one, we just want to know at what age are these children, are we seeing them? Second, it's also an indirect method of estimating the number of children who are exposed. So again, like Ada mentioned, if we are testing the mothers regularly, we expect more of the children who are exposed within 6 to 8 weeks. The moment you start seeing more children coming late, it means also those are indirect, it's an indirect way of saying that we do also have a number of people who are converting. So colleagues, on this part, what we are tracking are the samples, except for the initial rapid test, because that one we are doing it ourselves, the test. But the PCR one, it's the samples, whether the test was rejected or not, or what we're just trying to estimate. One, are the children who are exposed, and secondly, at what age or at what stage and age of this child are we seeing them? Are we seeing them in their early age or in their late age? Now move on to the other part.
It's not about the result.
No, it's not about result.
Okay.
But the result is where we are now moving towards to here.
Okay.
So the two are not necessarily related, because this part here, it's like, for example, in the month of March, all I'll report on are the children I saw for the first time in the month of March. And I'll allocate them their age group they belonged to. That's what I'll do. So like the way we have, this is April, this is May. So if you're reporting for April, all I'll report on are the children I saw in the month of April 2022. The next one now here, I'm now evaluating the infant who are exposed. As you know that in the PMTCT, when we talk of the HIV exposed infants, we track them for a period of 12 months. So here, what we are trying to say is that these children, we wait them until they clock 24 months. So these are the children, like in this example, excuse me, these are the children who were born in the month of April 2021, but we are reporting them in the month of April 2023, because this is when now, if it was a bank, I would have said, this is when it has matured. So this is when the children now have clocked their 24 months. So how are we going to deal with this cohort? One, okay, so one, how we deal with it is that if you look at the far end, we have got a net cohort, just like our payslip. So the net cohort are 24 months. These are the children a facility was responsible for. Now, how do we come up with this cohort? It's the children first, as we all know that a cohort in this regard, we are talking about the children who share the same birth of month, and they're all HIV exposed infant. But they may join the cohort at different points, like we earlier mentioned, because others, their mothers will convert, others, their mothers will move to another facility. Well, so what is key is that one, first, they should share the same month of birth, and then secondly, they should be HIV exposed. Now, so how do we come up with it? So we start down here by saying the net cohort. So these are the children who were exposed for that month. They share the same month. We'll add in the trans-in. Now, the trans-in should be HIV negative. So if you are going to have a trans-in with a transfer, and this child is already HIV positive, when they come to a facility, you're not tracking anything. So they have not transferred any services to you, but they have transferred other services to the ART department. The other aspect would move those again who come and say, I'm getting a transfer. Before 24 months, if anyone gets a transfer, again, we only remove those with a negative result. If a result was positive, it means the program failed and they're part of your analysis. So we'll add the negative transit and we'll subtract the negative transit. A transit which is positive, they're part of the analysis at 24 months. A positive trans-in, they're not part of the analysis. Then we'll wait for every child to reach 24 months and be able now to ascertain the outcome. So at 24 months, there are only 3 possible outcomes we expect. Either the child was infected, the child was uninfected, or the child status was unknown. And I should also make mention, colleagues, that for those who are going to classify as negative, we'll only be able to do so if we did a test at 24 months. A child may test negative along the way, and there's no risk of exposure. We may stop testing these children. But for us to confirm the final outcome of this child, we may suspend the testing along the way. But at 24 months, we have to test. So we'll only be able to say this child is negative. It's only for those we did the test at 24 months. And the child we're going to call unknown are those children, either they died before we had the confirmed result, but if they died and before they died, we had a confirmed positive, we record them under positive. But if they died before we had a confirmed HIV positive result, we'll classify them under unknown. A child will be lost for, meaning at 24 months, won't be able to see them, we'll classify them under unknown. So in short, the infected total, uninfected and unknown, the three variables, when we add them together, they should be able to give us the net HIV exposed cohort at 24 months. And our target is to ensure that at least 95% of this net cohort should be uninfected. And what would dilute that? It either be unknown or infected. Now let me come back to the infected. So don't confuse it with what was there before. So here, what we're just trying to say now is that because these children, doc, will be infected at different age groups. And in the register, we have categorically indicated that if a child is confirmed positive, the facility should even cross out and be able to indicate the final outcome in advance that the child is infected. Now, when they come to the final analysis, they'll now be able to add how many children for that cohort were infected. So if the answer is 10 children were infected, or what we want now to show, at what age group were they infected? So all of them are 24 months, except that what we're just trying to say is that of all these children who were infected, at what age were they infected? Again, it shows, because if you're going to have more children who are infected within 8 weeks, issues of surrounding the pregnancy interventions. If you're going to see more of the children who are being infected after 12 months, it also will point out issues of seroconversion. So it also gives us an idea of what was happening to these children, and also be able to separate them with regard to were these children breastfed or were not being breastfed, and what was the total of these children.
So, I know that we may not have enough time for questions. I really encourage the participant to put the question in the chat. And we have one question there saying, in an event, a facility runs out of TBS cards and some exposed children are seen, but samples not collected. How can this facility determine number of exposed infants seen from HIVTB?
Okay, so yeah, like I said it's an indirect method. So at the point when they'll be able to draw blood for that child, they will be able to document. So we're just trying to say it's an indirect method, but with regard to the actual program, it's the other one I was explaining. That one actually to also just give us it's just an estimate of how many children were exposed. Did we have in that year? So they can do the other, they may even draw blood the following month, or the following month, or they can even call the mother to come the following week. But in terms of the age, don't differentiate much. And also, it's just for us to just have an idea of at what age are we seeing these children.
Okay, thank you, Amapande, for your question. We can move on to the next
slide. So here, I think there is nothing much here. We're just trying to look at the linkage. And also what we're interested in is the age group of these children, whether they are 14 the adolescent and young people, and also the other adults. Here, the other aspect again you have brought in is the issue of childhood transitioning. You agree with me, colleagues, that So when it comes to the PIDs, at national level, for example, I think it also be similar to sub-national. You'll find that the figures have been floating almost the same numbers. Yes, on the other hand, we are saying the input, which is the EMTC, measure the EMTC, you're saying we have reduced the new infections for these. And on the other hand, the numbers don't seem to increase. On the other hand, again, we are saying, no, we are graduating. And we've also brought in the aspect of user-friendly regimen for the children, where we have the DTG and these other regimen, which also, in terms of the dropout rates and those roles to follow, are very minimal. But the numbers don't seem to increase. So one can also just see what is happening. So what you have now brought in is that we want to see of the 10 to 14 children, how many are transitioning to adulthood? So that's the number we expect people to document here. It's just the number of children. In the other month, there were 14. This month, they have now turned 15, meaning they're no longer part of the 10 to 14. So that's the number we expect. And again, colleagues, don't expect that the numbers we put here should even be more than the 10 to 14. The other aspect is just the age. It's just the age. We shifted from 0 to 2 to less than 1 and 1 to 4. And then here, what we wanted to track was the issue of retention by the 3 age groups and categories. Yeah, so but for now, I think we are unable to finish, we are unable to finalize. So for now, people will just be able to add the 3 and be able to see of those.
Kindly mute your mic.
Okay, so the other aspect on VMMC, it's just also realigning the age group. Nothing much has changed. With regard to the GBV or what we have just brought in, the new inclusions, whether one just ascertain whether it was a physical assault, male, female, or it was a sexual assault. And if it was a sexual assault, did they receive certain services of interest, which is, if it's a female, were they screened for pregnancy? Did we give them contraceptive for those who are eligible? Did we also screen them for STIs? Are they reactive? Did we screen them or test them for HIV? Were they positive? If they are positive, did you link them to treatment? And also, did you also offer psychosocial counseling to them? So these are just issues pertaining to the GBV. Also, with regard to PrEP, we have those initiated with PrEP. I know there's one question which always arises to say, is it now in the guidelines with regard to those who are 15 years and below? So for us, what we did was we provided for that. As we also know that sometimes you normally have emancipated minors, just like in MCH. Sometimes you do have those who are 15 years. So yes, it's debatable, but from our end, or what we just did was to provide, and then on the policy, they'll be able to advise. But there are always special cases. So we provided that for special cases in case, just like the example I gave of if a pregnant woman, probably she's even married traditionally and the right. The same thing with regard to those who have discontinued the PrEP. We just want to know how many have discontinued PrEP. So as we go towards the end, some of the things we need to remember are that data quality is a cornerstone of decision making. Several times, though, I hear people who sometimes don't take keen interest in the numbers, but it's through the numbers that certain decisions, either the government, the policymakers will come to. For example, like in the HIV programming as at now, the new business now is we want to focus on the main because the data has shown us, especially as the main, we don't want to be tested. Yeah. Data has also equally shown us that if we want to achieve endemic control, let's not leave behind the young people, the adolescents and young people, because that's why we're having more infections. So we could see that if you provide the data speaking to what is on the ground, people will be able to make decisions, the correct decision actually. So if our data submit is of high quality, the decisions people will make will also be able to yield results, because the data, the decision people are making is based on the data which is depicting of what is happening on the ground. The other aspect, just trying to emphasize, is that if you provide the data which is correct, on time, which is consistent and complete, it's also the backbone of data quality. So meaning people will be able to make decisions based on the data we have. But if our data is of not good quality, definitely we want to be able to have a correct data. The other aspect I want to just emphasize is that no data, no report, no service. I know people from the facility sometimes, I like giving an example about malaria, for example, no. There is a time where people would, because we are being discouraged from giving antimalarials in clinicals. Yeah. So what people would do is they would provide antimalarials Coartem, which was a clinical, they would provide, but they would not report. And then because they have not reported that number, when National Malaria Control, they're trying to procure, or some they want to give back the facility have ordered that they want 1,000, but they report that they only spent, or they only dished out 500, and they want 1,000 again. So what ZAMSA will do, they will say, we gave them 1,000, they want 1,000, but they're saying they only used how many? 500. They will give them another 500. Then they will report, say, no. We reported this. They are giving us less. It's because the product is based on the numbers. Equally, when it comes to issues of HIV testing, it's the same thing. If you underreport, it also means the product you'll be given, you'll be underreport, you'll be few products. And if there are few products, it means for other people, they won't be able to get the service. So all what we're just trying to encourage our colleagues is that if you don't provide the data, if you don't produce the correct data, there will be no product, because quantification is based on the numbers. And if there are no products, there will be no service. I end here, Chair.
Okay, thank you so much, Mr. Chimuka. I know that time has really gone. We really wanted to have an interactive session with our colleagues on the call. We can see that we received some questions, so kindly go through the question. But in the meantime, I would like to acknowledge the panel of our experts on the call, Mr. Peter Fusani, Mr. David Kula, Mr. Byron Sikapande, Mr. Mwango Butale, Melvis Wanza, Mr. Muiche Siame, and Mildred Tolosi. So if they are on the call, I think I'm going to give them time at least to input in case there's something that's missed in the presentation. But allow me to relaunch the poll. I'm not going to relaunch on it 6 because the first 4 ones. So colleagues, we shall go back to the polls to see if learning took place. So okay, I've relaunched. I think I've relaunched the first 4 questions. Chimuka Sianyinga, Boy Health Center, reported the following first ANC contacts. The following first ANC contact 100, non-HIV positive at first ANC 15, already on ART at first 17. The DHIO who received the above report from the facility, what correctly defined the situation. So the first option, the facility submitted incorrect data. The second one, the facility, the data submitted by the facility was correct. And the last one, it is difficult to determine if the data submitted by the facility was correct or incorrect unless the documents were reviewed. So, so far, how many people have voted? Yeah, so just vote. Oh, we are still at 21% voting rate. Colleagues, kindly vote so that we catch up with time. I don't think that this is a very difficult question. So we are expecting people to vote. So we are at 29% voting rate. Clinicians, they are the one producing data, but it seems they are doubting. When it comes to voting, they think that MNT people should come and vote for them. Thank you for those who are voting. So I'm going to end the poll now. We are at 34% voting rate, but it has reduced because initially we voted more than 50%. So I don't know if I should end the poll right now, or maybe we give a bit of chance.
We give a minute.
Okay, so kindly vote so that we can move on to the next poll question. We don't have much time. Only 1010 participants have voted out of 270 connections, 40% attendance rates. Let's reach at least 50%. Anyway, I'm going to end the poll right now. We are at 43%. And we can see that I'm sharing the results. So we can see that 73% have gone for option A. I don't know what is your comments, but we still have 19% who think that C is the correct result, and 8% B is the correct result.
Okay, so the correct answer, I think we have seen that there is a great improvement.
Yeah.
So the correct answer was A. Or what we're just trying to say here is that there are certain reports, by looking at the numbers, you don't even have to go to the facility and you verify.
Yeah.
You can tell that there are certain elements which are just wrong.
Okay.
So in this case, the unknown, we don't expect the unknown to be less than already on treatment.
Okay, thank you so much for that, for the answer. So we go back to question for question number 2. We are going to relaunch it as well. The question says, I think we can't see the, which one is correct about the reports of Ndeke on Mwelwa Sianyanda's outcome at 24 months? I think we can't see the.
No, so it's on 2 pages. The other one is on.
Okay, so kindly look at the slides. You can see the part missing on the question.
Can read it.
Mwelwa Sianyanda is an HIV-exposed child born on 10th April 2021 and is seeking HIV-related services at Ndeke Urban Center. When I was tested at birth, 6 weeks and 6 months, with all 3 tests being negative. At 7 months, when his mother got him a transfer to Location Urban Center, and the facility gave him the transfer on the same day.
It's not moving. It's supposed to move next. Okay.
So the question is here: which one is correct about the report of Ndeke? Yeah. And Mwelwa Sianyanda's outcome. So option A, his final outcome was negative. His final outcome was unknown. He was a loss to follow. And the last option is none of the above. I'm more concerned about the number of people who are voting. We don't expect it to decrease. We want more people to vote. Of course, we want also more people to pick the correct answer. I don't know which one is correct. So far, people are still voting. Only less than 100 people have voted out of the 262 participants we have. So for the sake of time, I'm going to end the poll and share the results. Okay, so we can see that the majority of people have gone for option D. I don't know what is your comments.
So I think again, we seem to have improved from 33% to 75%.
Yeah.
So all I can just say is that in terms of fund outcome, it's either infected, an infect which is negative, or unknown.
Yeah.
And only the facility who have not transferred out, I want to report on a child. So in this case, they transfer this child out. They have no jurisdiction about this child to report on the fund outcome.
Okay, thank you so much. Allow me just to share the last one.
Yes.
Yeah. The last poll question has been launched. Question number. Okay, all right. For question number 3. For question number 3, have people started the voting? Yeah, so what statement is correct about the HTS numbers reported on HIA2 reports on age and sex? Those numbers represent the HIV test. Okay, I've muted that one. So those numbers represent the HIV test from VCT only at a facility in a particular month. That was option A. B, those numbers represent all the HIV tests done at a facility in a particular month, excluding VMMC and PMTCT numbers, as they have their own section on HIA2 form. And the last one, those numbers represent all the HIV tests done at facility in a particular month. So this will be our last poll question. Less than 100%, 100 people have voted so far, and the voting rate stands at 38%. Let's vote, please. We are at 40% now. I'm going to end the poll here for the sake of time and share the results. Yes, Mr. Chimuka, you can see how people have voted.
Yes.
Your comment, please.
So again, here, I think we did a good job here. So 91% said it's C. So all the testing done, regardless of the service point, they should all be added to the HTS for positive and negative.
Okay, thank you so much. Our time has really gone. I don't know if we have some of our experts on the call. In case the presenter missed something, you can just unmute yourself and share your thoughts, comments, or maybe we also have some questions in the chat box. So in case our experts are there, I would like one or two of them to pick up the questions or maybe make a comment over the presentation. Over to you.
Okay, thank you very much. Just a quick one from my end. First of all, great job, Chimuka. Well presented. To my other colleagues on the call, we've been sending out queries of the observed violations in the system. Unfortunately, I think the rate at which we are responding to those queries is worrying. And if we continue on that trajectory, we risk being in the same position that we are in with the 2022 data. So mine is just an encouragement to all the colleagues on the call to really use the different applications that are at our disposal in the DHIS2 to clean out these errors. Then as regards to the validation rules, We are going to correct that very soon. We are currently working on updating the validation rules in the system following the realignment of our data collection tools. So mine is just an encouragement. Please, let's make sure we use all the tools available at our disposal to clean out the data. Some of the errors that we are seeing are things that are obvious, which can really be avoided. Thank you very much.
Thank you to you too, Madam Mildred Tolosi. I don't know if there is any other expert who would like to say something before we come back to our presenter. Okay, apparently she has said everything. So let's come back to you. There are a number of questions in the chat box. The first one is from Konje. On the part of DNA PCR initial test, we have always been relying on the result received in the month as test. Are you confirming those elements and now reporting on DBS sent to the lab as initial test data? Yeah.
Yes, so Konji, you're right. So as you may be aware, as you know, that for us to know how we have fared very well, we track a cohort. So the other aspect is what we'll be able to track on that part to just be the samples. But I should also quick to mention, probably maybe my colleagues Mildred and Angola will be able to mention that the other aspect we're trying to do, Doc, is that we're also trying to make things easier for people from our facilities. As we were aware that the DBS tests are done in our various laboratories dotted around the country, which are also connected to DISA. So the route we want to move to is that for the daily testing and positivity, I think people have credentials to be able to log in the DISA for them to be able to see how we are faring. So that's what you're trying to do. Probably I would have also expected the other issue of viral load, for example. Why is viral load not there now? So it's the same thing, because we want to avoid also, because we understand that some facilities, Doc, this is the same healthcare worker who has to see patients. She has to also do the reports. So certain reports which are generated by other systems, we are trying to remove them so that we also give room for our healthcare workers to also provide services and also be able to document. So that's the rationale of removing some of those data elements, because we can get them elsewhere. So what we are working on is to ensure that how do people have credentials into the DISA. At an appropriate time, people will be given those responses.
Okay, thank you so much. There is a question from Chipego Steve about the aging out of patient. How are we going to manage it? I think you come to that in your conclusion. Otherwise, you've mentioned that data quality is very important. Actually, the cornerstone for decision making, especially in the health sector, and correct data timeliness and all these qualities, consistent and completeness need to be observed. Yeah, and no data, no product, no services. So I think that has been noted. In conclusion, what can you say in summary? Because we've come to the end of our presentation. In summary, what can you say? I know that we didn't have enough time for us to receive questions. In case people want to reach out to you, because they can still ask questions even after the session. Are you able to share your contact details with them so that they can reach out and ask their questions?
Okay, so I can still share my contact, but I also wanted to make mention that for those information officers, we do have a group, a national group where people normally ask questions. Yeah. So also for it to be easier, I'm not trying to bring about bureaucracy, but it will also be helpful if they can go to the DHIOs to ask, because they may ask a very important question, which may also be able to benefit others. So I would recommend they ask the DHIOs. If the DHIO is unable to handle that, they would go to the SHIO, and then the SHIO also, if he's able to handle it, they will give the feedback. If they're unable, they'll bring it up. Why I've said that is because certain questions are very important. It may not just for the benefit of that person who would have asked, but it can also be replicated elsewhere. So I would recommend that they go to the DHIO, ask, and then they will also be able to respond. If they're unable, they will go up, because if they respond to them, it will be a very important question, but the amount of the audience or the constituencies the DHIO, the SHIO may have.
Okay, thank you so much, Mr. Chimuka Sianyinda. I need to remind our presenters that you are the strategic words.
Information officer. Actually,
information officer.
Yeah,
as the Minister of Health. And on the presentation, I was Dr. Onoya, HIVTB medical mentor under the Lusaka Provincial Health Office. Any announcement, Mr. Chatonda or Madam Kunda, before we end the meeting? Or Dr. Ziambo? There's a hand up from Lillian Namwanja. Kindly unmute yourself and share your thoughts in 1 minute time. She has lowered the hands. Okay, any announcement? Otherwise, thank you so much, colleagues, for having attended this meeting. For today, our meeting is ending here. See you next Monday. Bye-bye.
Bye. Bye, and thank you so much.
Bye-bye.
Bye.